Hello, I am your host, Dr. Jack Braha, and welcome to the Medcast Plus show. On this show, I will feature local healthcare providers to share their experiences and help educate us on different topics related to our well-being. You can view previous episodes on the web, and we welcome you to visit our website at medcastplus.com. Today, my guest is Dr. Krishna.GERD.Liver. Dr. Guram is a gastroenterologist here in Brooklyn. I am so happy to have another gastro on the show today. Welcome, Dr. Guram, to the show.
Thank you very much. It's a pleasure to be here, and anything I can do for the community, I'm here for them.
Well, that's the whole point of our show here, is really to educate our community at large about different healthcare topics. And gastroenterology has got to be one of the most common complaints when folks walk into the doctor's office, whether it's gas or bloat. They're worried about colon cancer, heartburn, and reflux. These are very, very common things. And so to have you on the show today is really an honor because you're a fellow Brooklyn gastroenterologist. Tell me, how do you like Brooklyn?
Brooklyn's great. You know, I grew up all over. I'm from Indiana. So when I come from Indiana to New York, it's a big change.
Well, there's less parking, right?
Less parking, yes. That's for sure. A lot more high-rises, no farmland.
No farmland, less parking. And because of the absence of parking and the presence of traffic, we get a lot more business, I think, in gastroenterology because people get an upset stomach and some heartburn while they're driving around our great city here. So you're in Brooklyn. Where are you working now in Brooklyn?
So I'm at the Brooklyn Hospital. I'm the Associate Program Director there for gastroenterology. I do interventional gastroenterology, which is more for the advanced endoscopy stuff. I did my transplant hepatology, which means pre and post liver transplant patients and take care of them. So we try to give them a good spectrum of GI healthcare there.
Yeah, so what Dr. Guram is explaining here is that he has trained extensively in gastroenterology. How many years of training does it take to become a gastroenterologist? Tell our viewers today how long the road is.
Well, it depends on if you really had to have a passion for it. As usual, you have to go to med school for 4 years. You got to do 3 years of internal medicine residency. I did 2 years of transplant hepatology because I really thought I wanted to be more of an for a liver transplant. Did 3 years of GI, gastroenterology, and another year of advanced. So if you add that.
Now Dr. Guram is 85 years old and a well-trained gastroenterologist. I got to tell you that my favorite part of my training in gastroenterology was doing transplant, and I was very lucky to be at Mount Sinai in Manhattan to do transplant. Where did you do your transplant training?
I did in University of Toronto. At that point, I wanted to do a lot more of living donor liver transplant evaluation and everything, and that kind of led me to that center. So it was a great experience, and again, it's different than Indiana, of course, in Toronto, but it has a lot of similarities to New York. So
yeah. Transplant to me is one of the most fascinating parts, and what Dr. Guram is explaining about living donor is where a person who is alive donates a part of their liver as opposed to deceased cadaveric donations where after someone passes, they choose to donate their organs. So it's an incredible thing. Now, liver transplant is a little bit less common than some of the disorders we're going to talk about today. Let's start our talk today a little bit about something that I see every day in my practice, and I'm sure that you do, heartburn, reflux disease.
That's right.
Explain to our viewers a little bit, what is heartburn?
Well, whenever you eat out or eat late and have extra hot sauce or something, you feel this little burning that occurs in your chest. And then you take some Tums and it goes away. That's basically what it is. It feels like it's in your chest and it's burning, and that's basically heartburn. And it's the most common GI side effect or symptom that people have and treat for.
I see it every day. Every day when I'm in the office, someone comes in and says, I have chest pain, which always worries me because you have to differentiate between a heart attack or some other catastrophic problem in the chest versus heartburn, right?
Definitely.
What are some of the features that you look for to say, hey, this is a guy or a gal that's got to be sent over to the ER when they're having this burn in the chest?
So, again, as you clearly mentioned, cardiac disease or heart disease is the first thing you got to think about. And it also depends on age. So if you get a younger person saying it's heartburn, it's less likely heart-related thing. But when you get an older gentleman in the 40s, 50s, and having this, you have to really differentiate that. If I see a person saying they're having more of a pressure and something going down their arm, or they feel very sweaty and they have shortness of breath, that's not really heartburn. They might have symptoms of heartburn at that time, which kind of mimics what it is, but that's something to get more concerned about.
Right, that's really important for our viewers to know that not every burn in the chest is because you ate a taco an hour ago. You know, it could actually be serious. And so what I always explain, or what I ask to the patients, is what you're describing. Do you get sweaty when this occurs? Or actually, one of the biggest questions I ask is, when you go up and down steps or you're exercising, does that bring back your heartburn, which we know is not really heartburn at that time? That's heart disease. So that's important for our viewers. Once you're able to say, hey, listen, I know that this is heartburn, GERD, gastroesophageal reflux disease, and it's not cardiac disease, how do you start off with counseling and treating the patient for this?
The most important thing is lifestyle modification, right? Just the things that they probably felt before, they're like, oh, I ate something bad. Those are all really related to their reflux. Now, whenever we have this reflux, it's a lack of or a little relaxation of the sphincter, which covers our food pipe to our stomach. It's right in that area. And it relaxes and you get reflux at that time.
This is the valve that keeps our esophagus closed. Right.
Yep.
And so when this relaxes a little bit too often or too much,
then you get that reflux.
Here we go again, right.
Yep.
So what do you do about diet? What's your recommendations?
So most important thing, eat early, at least, especially before dinner or so. Give 3 to 4 hours so that your stomach is not full, and then you go to bed and then you get reflux. You want at least 3 to 4 hours because that's what it takes to empty out. Then, of course, then the fun stuff comes in. Chocolate. If you love chocolate, well, that relaxes that sphincter again.
The chemicals in chocolate.
Exactly.
Sometimes the caffeine.
The caffeine
right.
from coffee, alcohol. So all the goodies we want to enjoy a little bit later in the evening or have fun can all make the symptoms of reflux worse.
Right, isn't there, what's that chocolate, like after 8 or after 10, or I don't know what it's called in the supermarket I see sometimes, where it's chocolate and mint together.
Mint together.
And that's the devil for
that
us.
That is, especially if you have peppermint. That's another thing that relaxes everything and you get reflux. So maybe not the best choice.
Right, so when I see the patients in the office, I ask them, well, what time do you eat dinner? And you mentioned this about how long does it take for the stomach to empty. And that's a really important thing to educate patients on, and for our viewers today, is that, listen, the stomach, when you eat your meal, doesn't empty immediately. And so when they get home at night, I do exactly what you're saying. Eat early. I ask that they walk around also to try to empty the stomach. What about when they get into bed?
So if you're still having symptoms and you waited 3-4 hours, but you're still having some reflux, naturally we tend to have more reflux at night because there's no gravity. We're just lying flat. So sometimes I tell them you can put an extra pillow in there, or if it's getting bad, put a wedge so that it lifts the bed up a little bit, or you can lie back where you're not fully flat, and that prevents that acid from reflux.
Raising that area to draw the acid or the reflux back down into the stomach is
exactly.
important.
Yeah.
So say I'm your patient. I pretended maybe to listen to your dietary suggestions. I eliminated my coffee. I eliminated the peppermint I eat at night. I got rid of the chocolate milkshake I have every day, and I'm still having heartburn. What are the other things in my life that could be causing or making my heartburn worse?
Well, I think stress definitely has that. I mean, we know stress makes a huge impact in whatever we are. Whenever we're in stress, we have even sometimes diarrhea, sometimes heartburn, and everything else. But I think the next thing is, if everything you're doing and you're really sticking to it is not really working, then you got to think about, well, what other medications can I take to help my symptoms?
Yeah, there are medical treatments. We always, in my practice at least, I try, and I see that you probably do the same, to counsel patients about how to change their life. They can easily fix heartburn by diet, losing weight. We should talk about that a little bit. We know that the waist size, right? As waist size goes up,
they get more reflux.
They get more reflux. So I try to counsel on diet and exercise. You mentioned some medications. Let's talk about these medications. What are you using? What type of drugs can we use for heartburn symptoms?
So if it's once in a while, I usually say, well, take some luminal antacids. What that means is acid, when acid is there, you give something, it mixes with it, takes the acid away. So that's where you start using Tums, Mylanta. I try to stay away from Tums. I know they say calcium is good for you, but I know calcium sometimes gets the acid reflux back a little bit later, so that's still good if you need it at that point. Now let's just say that once in a while is becoming a little bit more often and you don't want to pop pills or drink something every time. The other thing that I try to do is start with other medications that are over the counter like Zantac and Prilosec, which suppresses the acid to a level. But know that if you keep using that often as well, it won't last. Your body gets used to it, and you get sometimes more of a response of more acid.
Right, so these medicines, like what are known as H2RA blockers, histamine 2 receptor blockers, decrease acid. They were one of the first drugs that were game changers decades ago when I guess you and I were babies at this point.
Yes.
But then the next class of drugs, the PPIs, which we all hear about on TV, they're on the news quite a bit, there are plenty of advertisements, like Nexium, other medications like that, they really get the acid level down.
That is the gold, I guess, the standard of treatment for any acid. I mean, if they're not working, you got to really think twice, why aren't they working? These things really shut down the acid pump and they calm everything down. I mean, after, like you're saying, when we started having the H2 blockers and the PPIs, before they were doing surgeries for ulcers and everything.
Yeah.
Now with these medications, those surgeries for ulcers have disappeared.
They are rarely, if ever, done.
Yep.
I think back in the 80s and in the 70s, they were done quite more frequently.
Yep.
When you talk to surgeons who have a little more experience under their belt, they used to do these all week long, many, many cases. Yep. Thank God for these drugs, because patients don't have to go into the knife. Beyond the medications, beyond the lifestyle changes, you know, as gastroenterologists, we do endoscopies. Yep. These are little camera tests that we do when the patient's sedated, take only a few minutes. When do you make that decision to do an upper endoscopy on a patient with GERD?
It's not supposed to change that way. Right. So when it starts changing that way, it doesn't follow the right pattern. And that over time can lead to adenocarcinoma or cancer of the lower esophagus.
Right, so for our viewers, reflux disease itself actually is a risk factor to develop cancer of the food pipe. Absolutely. And it starts off often as what we call Barrett's esophagus. And so Barrett's esophagus develops in, say, a 50-some-odd-year-old gentleman who we bring in for an endoscopy one day. We do the endoscopy, takes a few minutes. We look inside, we find the Barrett's. We take a biopsy. If the biopsy shows Barrett's, plain old Barrett's, without any advanced features that say, hey, listen, this is going to become a cancer soon, what is the next step? How are you treating this gentleman? What is the surveillance that you might do? Tell us how you're going to make the plan of care for this type of a patient.
Most of the time, it's suppressing the acid. So if they don't have a little bit of the stomach slipping up called hiatal hernia, or I usually put them on PPI, like omeprazole or Prilosec, Nexium, whatever it is, to suppress that acid. And usually, because the constant acid exposure is the one that tend to make it into cancer, once you suppress that, you can just follow by doing routine endoscopies every 3 to 5 years. I like to be a little bit more conservative because if we can catch anything early and take care of it, that's better than pushing it off to a little bit later. So I would bring them back, I'd see how they're doing with their symptoms. Sometimes they have no symptoms, so I just follow them, and then every 3 years I do an endoscopy.
Yeah, I agree with you. Every 3 years I bring them back. If there's a change in the symptoms also, I'll do an earlier endoscopy.
Definitely.
You'd agree with that, right?
Yep.
The sensation of food sticking.
That's an alarm. Yeah, that's a big alarm sign. So anytime they say there's food sticking, I'm noticing I'm getting weaker, and at the same time I have low appetite and weight loss. All those things, those are very big alarm signs. So I got to differentiate at that time. Is this acid coming up and causing narrowing or strictures, as we call it, or is this turning from Barrett's into the cancer that we have?
Right. So I in my practice, if there's any of these alarming features, and we call these red flags, alarm features, difficulty swallowing, the sensation of food sticking, I bring them back right away.
Yep.
that could be a sign of cancer. And that's even without Barrett's esophagus. If a young patient shows up and has difficulty swallowing, we do an endoscopy. And the reason is also there's a condition called EOE, eosinophilic esophagitis. We should touch on that for a little bit because we probably have a great deal of young viewers out there. And this is a disease I tend to find quite a bit in young people. Tell us a little bit about EOE, eosinophilic esophagitis. Have you seen it at all?
Oh yeah, lots of times. Majority of the time, the patients who come in, young kids don't really come in with heartburn. They don't want to say they have heartburn. They don't want to say that, even if they have something sticking, they don't want to come in to see a doctor.
But they're also the first ones to admit that it's after eating a heavy meal from the food court at the mall.
Definitely. And most of the times when I see these patients, they're coming into my ER saying something's stuck and I can't get it out. It's a food impaction they're having. So I'm going in the middle of the night trying to retrieve whatever food is getting obstructed. When we relieve it, we look at the mucosa, the lining of the esophagus, say, this looks a little bit abnormal. We take biopsies, and that's when we see lots of eosinophils.
These are the red, they light up red on the microscope.
That's
these cells, yeah.
These cells, and these cells are predominant in this situation. Now, it's interesting because there's something called PPI responsive EOE or plain old EOE.
That's the fork in the road we deal with.
That's right.
Which is patients who get better with Nexium. And the EOE goes away, and then there are the folks where it doesn't go away.
That's right.
And that's tough to treat. What are you doing right now with your EOE patients? They come into you after meeting in the ER, you took the biopsies, you tell them, hey, listen, you've got this disorder. What's the next step? How are you going to treat them?
So initially, right after the food impaction, I don't want to do anything because I want them to heal a little bit in that area. Then when I bring them back to clinic and we got the biopsies and everything, I'll say, let's try to avoid some foods. Again, I always try to do natural stuff, lifestyle modifications, see what it is. Right. And we know there are some things that really can exacerbate EOE. This includes nuts, milk, egg, and there's a
soy
is another big one. Yeah. So all these things. So we try the elimination diet. At the same time, I tell them you should also go and meet an allergist to see what other food allergies you have. Maybe that could be exacerbating this as well. And then I start treating them from my end. And usually we use light steroids, topical steroids. Sometimes you might think that they have asthma, they're using inhalers, but they're not inhaling it. They're just swallowing it. And that steroid that's in those inhalers, whatever, when they swallow, that coats down their esophagus or the food pipe and really gets into that area.
The steroid reduces that inflammatory response. I always get a phone call from the pharmacist when I write the prescription, swallow the inhaler, wondering if I'm crazy. And I always tell the pharmacist we're treating EOE. I often send them an article to update because it's an unusual way to take an inhaler. The patients actually puff the steroid, and instead of inhaling it into the lungs, we swallow it to treat the EOE. I like your point about the allergist. I always refer the patients to see because this obviously was stirred up by something, and it would be nice to figure it out. With adults, it's really hard to do elimination diet to restrict these food products because they're often in many of the food products that we eat. So EOE is another thing we might find in patients. Barrett's we might find. Let's move on to something that I know you want to talk about today, which is when someone has difficulty swallowing or pain in the chest, sometimes we find a condition called achalasia.
Yes.
To educate us on this word that many of our viewers probably have never heard.
Well, achalasia is basically a Greek term, and where it says it's a failure to relax. And this is what happens when our food relax of the
most of us New Yorkers have a failure to relax, right? But this is a failure of the esophagus. Which part?
So the lower part of the esophagus, which is actually what we call the sphincter, which should be working well to prevent reflux, is working a little too hard where it's not relaxing.
The valve is clamped down.
The valve is clamped down. Right. So when the food comes down, it should open up and let the food enter from the esophagus into your stomach. When it doesn't do that, you start building up. It starts getting pressure. And then after a while, it'll go down because it's a physics thing. The pressure on top is higher than what's holding here, it'll go down. As it gets worse and worse, that's when people will start coming to you to figure out what's going on.
I've been called in the middle of the night to the ER. I've had to take patients for endoscopies, and they don't know the diagnosis. And to get one little piece of chicken out when someone gets that stuck is actually a little bit easier. When it's achalasia, the entire esophagus can fill up.
Yes.
And the sphincter is very hard to overcome, and we can spend hours pulling food out of the esophagus. And I've been there in the middle of the night. I remember one case from 2 to 4 o'clock in the morning, evacuating the esophagus. What are some of the treatment options out there that you can offer patients with achalasia?
So first thing I always try to do, even with achalasia, is this achalasia or pseudo-achalasia? And I think this is very important because when we go in there, we feel like, oh yeah, it's tense in there. We're trying to push through to come into the stomach with the endoscope. And then I always want to rule out by first thing, just doing an endoscopic ultrasound or a CT scan to make sure they don't have cancer there that's mimicking this disease of achalasia.
A tumor can actually present very similarly. Patients can have the same exact symptoms.
So once I do an EUS or CT scan and I don't find anything that I'm concerned about, then I say, well, you have achalasia. Let's try to identify what type of achalasia you have. There's multiple types. And once we identify, we do something called a manometry. It's like a pressure curving and seeing how you swallow. Once we identify, we say, first thing, if you want, you don't want to be too aggressive, we can try Botox. And you're thinking, Botox, when I give that into my face, what are you doing?
I know when I inject it in the clinic and I'm doing an achalasia patient, the nurses always joke around, can I have the extra for my wrinkles?
That's right.
And they're wondering, why are we putting Botox in the esophagus? But it actually can help with achalasia.
Exactly.
What about other options where we're more invasive, where you can actually cut the problem, the muscle that is causing the problem? Tell us a little bit about that.
Well, in the old days, until the last 10 years, I would say the gold standard would be something called a Heller myotomy. A surgeon comes in, he cuts the muscle laparoscopically or open, and then relieves that tension there so all the food goes down.
You can do this a lot different now,
That's
correct?
right. It's changed, it's night and day from what it was 10 years ago. Now, endoscopically, we can go into the layers of the esophagus through the mouth without any cutting from external areas.
No scar.
No scar. Go in from there, make a tunnel, we call it, in the esophagus all the way down to the stomach, and cut that muscle that's really tight there, open it up,
I've seen
and come
this.
out.
It's incredible. It's
It
incredible.
is.
And it works.
It's amazing.
It's called a poem.
A poem procedure.
It's not a literature, it's not in a book, it's not a fun poem to read. It actually stands for something. Tell us what it stands for, poem.
Poem means per oral, that means it's going through the mouth. Endoscopic, with the endoscope, we do a myotomy, which is cutting the muscle.
Right.
So we make it look like poetry in there.
Yeah,
but
it does look good. It's incredible what can be done for achalasia now as compared to maybe even 10 or 15 years ago. We covered a lot today about upper gastrointestinal symptoms. We talked about heartburn today. We talked about reflux. I think we really covered a great deal for our viewers today. The most important part is those alarm features. And in our last 30 seconds here, let's go over that again. What are some of the alarm features where a patient should run right away and come see their gastroenterologist?
So if they have difficulty swallowing, they're having weight loss, they're fatigued, they have low appetite, and anemia, any of these things that are there, that's the first thing you do. And if you're above the age of 50, and especially this is common in white males,
Come get checked.
Come get checked.
Yeah. So we really covered a great deal of gastroenterology today with Dr. Guram. Thank you for checking in and viewing our latest episode of Medcast Plus. You can visit us on our website, medcastplus.com. Remember, the topics discussed today do not replace your meeting with your primary care or gastroenterologist. These are just to help educate, but not to direct your care. If you have any significant symptoms or medical issues, please speak with your primary care doctor. This is the best way to cover yourself and make sure that you're not missing any significant diseases. You can reach out to us on social media or reach us by phone at 718-510-2103. I'm your host, Dr. Jack Braha. Thank you for viewing. Stay well, stay healthy, Brooklyn, and goodbye.